Thank you so much, Dr. Garrido-Castro. And you can stay up. We're going to invite all of our morning speakers to join Dr. Sharma, who's going to do a moderated panel discussion with some case studies. And then pinch hitting for Dr. Shane Steckline is the Dr. Julia White. So she's from our professor in radiation oncology at the University of Kansas Cancer Center.
Thank you for wonderful talks this morning. So we'll start with some of cases that I've kind of put together for us to go through complicated scenarios and decision making. If I can have my slides. Okay, we'll start with case one. And I think Dr. Cobain may have touched on this a little bit in a triple negative setting. So this is a 48-year-old with a screen-detected left breast cancer. On imaging, there's a 1.8 centimeter mass and negative axillary findings on ultrasound. On biopsy, this is grade 3, ERPR negative, HER2 positive. And how would you approach this lady with a T1C cancer? Surgery first, followed by kind of APT regimen or neoadjuvant therapy. If neoadjuvant therapy, how aggressive would you want to be? And since, Erin, you did that talk, I might start with you.
Yeah, for sure.
Yes.
So I think that for these patients that have a clinical T1C N0, in this case, obviously it's a HER2 positive, so a little bit different from what I talked about. I think the main concern you have is the possibility that with neoadjuvant systemic therapy, this patient could be overtreated. The data would suggest that if indeed on final pathology, this is an under 2 centimeter node negative cancer, that the outcome would be excellent with adjuvant Taxol Herceptin if this patient proceeded to upfront surgery. Of course, right, just as we explored in the case of a T1N0 triple negative breast cancer, there are always the cases like this that we send to upfront surgery, and then after the fact, there may be lymph node involvement, and then we sort of say, gosh, maybe we wish we would have done the neoadjuvant systemic therapy, because then it would have given the opportunity for us to tailor the adjuvant systemic therapy, if there was an ideal response. But I think in these scenarios, it's appropriate to consider upfront surgery and then subsequent taxane trastuzumab in the adjuvant setting. I think we're all really eager to see the data from the COMPASS trial that will explore the neoadjuvant treatment regimen of taxane alone, Herceptin Perjeta, the opportunity to sort of de-escalate the chemotherapy backbone of Taxotere carboplatin, which does carry with it a substantial amount of toxicity. And if we see that data and indeed the outcomes are excellent from that trial, might we revisit the patients that we're giving neoadjuvant systemic therapy to because of the fact that maybe it won't be quite as toxic to give 2 drugs, right, in this setting, which is sort of what we're stuck with right now, at least per standard of care. The other thing I just want to emphasize about cases like this, I also really think the axillary imaging here is so important. Meaning that even if the patient is clinically node negative by exam, these are the cases where it's so important to make sure that the patient has had an axillary ultrasound, because if there were to be an abnormal appearing lymph node and documented axillary lymph node involvement, you would totally change your thinking on this if it was positive, and neoadjuvant systemic therapy would be very appropriate.
Angie, Anna? Different thoughts, agree?
I do agree with everything you've said, and I will just say, so I'm one of the investigators on the COMPASS trial, and we will be seeing PCR data from that trial at ASCO this year. So I think that's, we're all looking forward to that, because I do think we need to understand who are the patients in whom we can de-escalate or more tailor the therapy up front. And so, and then of course we'll need the outcome data to make sure that if we do give less therapy to get to PCR, that we're not compromising on the event-free survival. So I think that was the main issue that I wanted to bring up, is really just trying to be as careful as we can about patient selection. We're looking in the I-SPY trial also at how much benefit the addition of AC gives you in the neoadjuvant setting. And so in I-SPY, we now have a design in which we can model based on imaging and a biopsy after the taxane component of the treatment, whether or not we think a patient is at PCR. And if we think they are, they go to surgery early versus stay on treatment. And that's helped us to start to sort out which patients actually might need the AC or need more therapy. And maybe we can take also a more stepwise approach where rather than just deciding on a regimen right up front, we can be making decisions as we go based on how patients are responding. So I think that's hopefully where we're heading, so we can truly tailor, individualize our therapy. But like you, I would probably give neoadjuvant therapy to this patient just to give them the benefit of the doubt to get to a PCR, have the best opportunity to not have to escalate therapy on the back end, recognizing there still could be a risk of over-treating them up front.
And then just like we talked about, it could be smaller at surgery, it could be bigger at surgery, and even at this tumor size, about 10 to 15% of these patients, even with imaging negative axilla, will have axillary positive disease. And the
I think it's also super important just, to talk this through and get the gestalt of what your patient's preference is, right? There will be some people that express a strong desire to very much avoid overtreatment. There will be other patients who express a strong desire that I would be willing to accept slight overtreatment if I was assured, right, that I was doing everything that I could, right, to achieve the best outcome. So I think sometimes this decision is also a little bit dictated by which way the patient is leaning.
Yes.
And the PCR or lack thereof has such a strong prognostic value and helps patients kind of wrap their head around, is this going to come back or not? Anna?
No, I fully agree with what both Dr. Cobain and Dr. Michelle have mentioned. I would say for these T1C clinically node-negative tumors, for those that are over 1.5 centimeters, I tend to favor, as Dr. Michelle was pointing out for the reasons that she noted, doing preoperative therapy, acknowledging that there is a chance that you're over-treating. But I do think that both for axillary management, even if clinically node-negative, there still is a proportion of patients who will have a nodal disease, and also because of the prognostic information that the PCR, that pathological response will provide, in addition to our ability to tailor adjuvant therapy afterwards. For particularly those larger T1C tumors, I do consider doing preoperative therapy.
Yes.
So if I could just make a local regional comment on this patient, because I think it's important. So these patients do, even in this very young woman, do extremely well with breast-conserving therapy, provided she's, she's not BRCA positive. And in fact, they do so well that we think that we can perhaps omit the radiation in them. So there's an ongoing clinical trial, NRG-BR008, or the HERO trial, where patients who have tumors actually up to 4 centimeter clinically node-negative prior to neoadjuvant, if they get a PCR, they're candidates for being randomized to radiation post lumpectomy versus not. Or if they have a tumor up to 3 centimeters clinically node-negative, proven to be negative with upfront surgery, similarly are eligible for the trial. So I think it's a great question. I personally, my favorite arm is the neoadjuvant arm. I'm just going to give you my bias. The small disease, the PCR, I think they're really ripe for lumpectomy alone as their breast conservation treatment without radiation, but we need the trial to finish. Appreciate help.
Do any of you use mid-treatment imaging to tailor therapy? So this is a situation where, 6 cycles of TCHP may be an overkill, maybe 4 is adequate, maybe 4 of THP is adequate till we get more data from Compass. Do you rely on MRIs to see if it's, or you commit to 6 cycles, or you commit to whatever duration you started out with?
Tend to commit to the recommended treatment plan and repeat the imaging close to the end of treatment. I do think there are some studies that are starting to show that you may be able to use imaging to help tailor therapy. But I think we need additional data to be able to support that. And currently, I would.
And a lot more robust data with PET, but we typically have trouble getting PETs approved.
Exactly.
And again, I will say another part of the I-SPY current way that the trial is running is there is a midpoint MRI, and then patients actually can add the carboplatin if they are not having a great response to THP alone. So these kinds of strategies, I think, will be really helpful in the future, but should only be done on a clinical trial.
Yeah, agreed.
Would you all think differently about approach if this was an older patient but in good health? So does age itself influence the decision? Angie and Anna, you're like T1C or more than 1.5 centimeter neoadjuvant approach to go. It was a 68 versus 48, but in good health. Would you still have the same recommendation?
I used to think it mattered, and then I got older. And now I'm like, wait a minute. Now what's old, right? 68? Not that old. If you said 86, okay, maybe I would change my management, but not 68.
I agree.
And what if this was ER positive and grade 2 instead of ER negative and grade 3, but still HER2 positive, which we seem to see a lot more ER positive, HER2 positive cancers. And I like your approach, Angie. These are ER positive cancers that are also HER2 positive, right? So not the other way around.
Yeah.
You're still endorsing preoperative something to give them the benefit of doubt of adjuvant TDM and other things?
Yeah, I am, but I think we have to really start thinking about these tumors. What are we going to do for them in the adjuvant setting after neoadjuvant therapy? And do we expect to see a PCR? There is a difference if you look at the meta-analysis. And then how long do we give our endocrine therapy? I mean, there's so many unanswered questions in these dual positive patients in the early stage setting.
Is COMPASS allowing T1Cs, or it's only stage 2?
Yes, no, it's stage 2,
stage
only
two.
stage 2.
Yeah.
Right, so
It's a pity the T1Cs are excluded from almost all
Right.
pivotal trials.
That's what I was just going to say. This is the patient you would have loved to have put on COMPASS,
Yes.
right? Because this is the patient in front of you who you feel like is borderline. You can have a good argument for doing neoadjuvant systemic therapy, but it is a big jump between Taxol Herceptin in the adjuvant setting and TCHP in the neoadjuvant setting. And so I think that if we see the data from COMPASS, albeit this patient wouldn't have been eligible to participate, if that is promising, you could see us sort of extrapolating that potentially to this scenario and it being sort of an ideal fit.
Yeah.
I will also say we've collected tumor in COMPASS, and so we will be able to do biomarkers, which I think will also be incredibly helpful in terms of deciding which route to go in these patients.
Yeah. HER2-DXd would be great to have with
DXd
COMPASS, yes.
is
Yeah.
being done as we speak, yeah.
So this patient ended up receiving neoadjuvant therapy, kind of, lighter version of it with THP, omission of carbo, and at the time of surgery, I had lumpectomy, but there was a 6 millimeter residual cancer with negative axillary sentinel lymph nodes. Does all of this history inform breast radiation discussion? What would you discuss with this patient in terms of radiation, the course of radiation, number of days, et cetera?
So I think this is unfortunately, if she had upfront chemo and THP and has residual disease, she then is not a candidate for the omission of radiation. Personally, this is why I love the neoadjuvant way of getting in energy BR008, because you're really selecting the good actors in response to HER2. And in my heart of hearts, I think those are the patients that probably don't need radiation after a lumpectomy. So this patient, I personally would still treat with standard whole breast irradiation in someone who's younger, who cares about her cosmetic outcome in the long run. It's 15 treatments where we dose the whole breast to a lower dose, concomitantly giving a higher dose around the high-risk region, as long as we can find where the tumor used to lie. In my hands, I don't use accelerated partial breast irradiation. In women over age 70, we offer them an accelerated whole breast irradiation of just the 5 treatments. So it's kind of business as usual for the breast radiation.
Yeah. So not the 5-day radiation that we see.
I think there's a lot of excitement based on the FAST trial, the Fast Forward trial, where they gave 5 radiation doses. for whole breast irradiation. It's just a single trial. It was done in the UK where radiotherapy is planned a little bit differently. And so what you look at, if you look at the nitty-gritty in it, I think the dose is good. There's been a lot of, the radiobiologists are kind of in a little bit of an uproar because they feel like it's a little bit too low a dose for patients with higher risks of recurrence. So in a younger woman, you might not want to use that. But if you look then, particularly, in breast conservation, we have two goals. We're trying to control their disease, and we want that breast to look good for as long as possible. It doesn't make sense otherwise, right? And so when you look at women who have large breasts who are under age 50, they had much more unacceptable toxicity, marked fibrosis. So we have to be careful because radiation, we know radiation in small packages daily is a little bit better tolerated than large packages, depending on a lot of factors. And so I think there's a lot of upcoming data that will help solidify whether 5 fractions can be used. In women who are over age 70, I've been careful not to make an assumption of how they feel about the look of their breasts. I've had a lot of them yell at me and say, how dare I? Give them only 5 when they know it might give them worse cosmetic outcomes. So please know I don't mean to be ageist, especially since I'm about that age. But right now, in a young woman, particularly if she has a large breast, or she's had an beautiful oncoplastic surgery, I would not give 5 treatments. It should be a moderate hypofractionation. 15 or 16 followed by a sequential boost if you want to boost, or right now all the data for boosting, if you have appropriate technology and appropriate skills with your technology, should be done in 3 weeks.
Thank you. Okay, case 2 is a 51-year-old with screen-detected left breast cancer. On imaging, there's a 1.7 centimeter mass and negative axillary finding. Grade 3 ER/PR and HER2 negative, Ki-67 50%. How would you approach this individual? She does not have any contraindication for immunotherapy, and germline testing is negative. The Keynote 522 or Pembro is approved in high-risk triple-negative breast cancer, and it's in the eyes of the beholder what we define as high risk. Would you send the patient to surgery first, followed by adjuvant therapy, neoadjuvant chemo? Would you have a discussion about neoadjuvant immunotherapy in that person?
So I actually think this is sort of the crux of what we've discussed in my talk. And one thing I didn't mention that I do want to mention, I think a lot of times for these tumors that are really close to being over that 2 centimeter mark, we talk a lot in tumor board about, especially in a young, otherwise healthy patient, should we get an MRI and see if the measurement's different? What if on my clinical exam, I'm measuring it as 2.3 centimeters, but the imaging tells me it's 1.7? I will tell you that if I have a measurement that meets criteria for Keynote 522 regimen and the patient is young, otherwise healthy, desirous of sort of maximal systemic therapy in an effort to improve their outcome, I think we go with that approach, right? Meaning if I measure it on my clinical exam as being over 2 centimeters, if I have an MRI that suggests it would have met criteria for Keynote 522, then I go with that approach. But I think in the circumstance where it's clearly a T1C, I don't think that, they wouldn't have been eligible, right, for participation in Keynote 522, but these are the cases where I do think neoadjuvant chemotherapy is very appropriate to consider because of the opportunity, just like this we talked about in the setting of the patient with T1C and 0 HER2 positive breast cancer, there's that opportunity that if they have residual disease, we can give adjuvant systemic therapy that might further improve their outcome.
I have to say, I saw a patient just like this last week, although 41, not 51, and the path had anaplastic features. And I think there are these subtleties, and there were maybe a couple of satellite lesions near the tumor. So these subtleties of, maybe a little more aggressive biology, if you have anaplastic or metaplastic features, also pushed me over. When I looked at the MRI with the radiologist, she was like, well, it could be 1.7, but if I move it just slightly, it could be 1.9. So we did end up doing immunotherapy because I don't want to end up in a situation where I don't have a path CR and feel like I've missed the opportunity.
And, we have OS benefit from Keynote 522, and we all know immunotherapy after surgery. It's not like HER2 therapy where you can give it after surgery and it works almost equally well.
But it was a lot of conversation with the patient and really explaining the risks of the immunotherapy and these, things like adrenal insufficiency or hypothyroidism that could be lifelong. And this matters to a 40-year-old. So it's not it's a long conversation.
I fully agree. I think if, in this case, imaging, exam, all imaging modalities and exam confirm a 1.7 centimeter tumor, I would favor a neoadjuvant approach, but I would offer likely ACT chemotherapy for, in the neoadjuvant setting. And if the patient did have any residual disease after, at the time of surgery, then would talk to the patient about capecitabine. If, I fully agree, if on imaging or on physical exam, the patient would meet Keynote 522 criteria, then I would offer the Keynote 522 regimen. I think there's a chance that we are significantly over-treating many patients in that space, but just like Angie just mentioned, and I don't want to be in a situation where you feel like you've missed the opportunity in a T2 triple negative tumor where you have not achieved a PCR, and there's the potential that you may improve that with the addition of additional chemotherapy plus the immune checkpoint inhibition. I think one thing that we're also increasingly seeing now in our pathology reports is TILs being reported. And interested also to hear if that influences anyone's recommendations. I know that I've used it specifically to help decide whether or not to give a particular approach, but we do know that tumor-infiltrating lymphocytes are prognostic and predictive of pathologic response, complete response here in triple-negative breast cancer. And so, if this were a smaller tumor with a high level of TILs, one might argue against obviously a neoadjuvant approach, and one could even discuss whether you might use TILs to guide your adjuvant systemic therapy approach. But here, for this specific case, as noted, I would offer neoadjuvant ACT.
Do you get quantification on TILs or just presence, absence, or high, low?
We get quantification of TILs in the path reports.
Yeah.
I do think we're at a tipping point with TILs that in the next year or two, we are going to start thinking about using them. We have to get familiar with it. Our pathologists have to get comfortable. And I think, whether you can differentiate between 20% and 30% is probably unrealistic, but you can differentiate between 75, 50, 30, and those cutoffs seem to matter.
And there's data from several big retrospective studies. If you have a node-negative, triple-negative breast cancer with greater than 30% TILs with just chemotherapy, and this was not even anthracycline chemotherapy, the 5-year OS is greater than 95%. So you really wouldn't be able to move that needle much. And this is all node-negative, right? So not just T1Cs. So it'd be hard to move the needle in T1Cs. But on the flip side, the same node-negatives, even T1Cs that had lower TILs, the 5-year survival is in the order of 86% or so. So it's just a huge difference. So you don't want to miss the opportunity, but you just don't know who you're going to miss the opportunity in.
And I think it's also striking when you look at the Kaplan-Meier curves from the Keynote 522 study, when you look at the group of patients that had pathologic complete response, regardless of whether or not they got chemo alone or they got chemo plus immunotherapy, they do exceptionally well. And so there are probably a proportion of patients that would do just fine with chemotherapy alone. It's just who are they?
And we've always known that.
Right, we've always known
PCR with TNBC and HER2 positive with just chemo alone, they've always done well.
Right.
So, I mean, the next point would be if the patient was slightly younger, would that change anybody's recommendations? What if the patient had a germline BRCA1 mutation? Because, they're, right now as this person stands, if they went to surgery first, they wouldn't quite meet the criteria for Olympia, but if they didn't have a PCR, they would.
They would, right?
Yes.
So you miss the opportunity if you do not give neoadjuvant systemic therapy to potentially give olaparib as a part of their treatment.
Yeah. So that would even push you towards, and for like germline BRCA1 carriers, let's say it was a 1.2 centimeter tumor, would that influence your decision to do a neoadjuvant? So
That's a tough question. For a 1.2 centimeter tumor, I will say, again, my threshold to want to favor doing a neoadjuvant approach is around the 1.5 centimeter mark. 1.2 centimeters, you really feel like you may be significantly over-treating the patient by giving them ACT chemotherapy. That said, the patient also has a high likelihood of achieving a PCR with neoadjuvant treatment. And given what we know with the olaparib data, I have to say I probably would consider doing it. I would talk to the patient about doing neoadjuvant therapy and what are the risks of potentially overtreating versus going to surgery first and what our options are later. But I think as we see these clinical trials reporting out on how we can tailor our adjuvant approach based on preoperative therapy and how that impacts overall survival, including overall survival, I think we're shifting more towards a pre-op approach for these T1C clinically node-negative tumors. I don't know if others feel differently.
I mean, but the sad part is still the T1Cs are excluded from most of our trials. Scarlet also, we were made to exclude them. We wanted to, but we couldn't. So this is a huge proportion of patients that we're still pretty much giving systemic therapy to, but we can't use our clinical trial data to inform decisions.
So we need a trial in this space for sure.
Yes.
I think it's also, we want to support the Optimize trial, which is looking at whether we can shorten the duration of postoperative adjuvant therapy, adjuvant immunotherapy, because, not all of the toxicity is in the neoadjuvant part of that therapy. And when we talk about overtreatment, it would be really nice to be able to give less adjuvant immunotherapy to these patients. So that would reduce the concerns about overtreatment.
And to the point made about including T1Cs in clinical trials, so my colleague Dr. Erin Cobain is conducting through TBCRC a study looking at the PARP inhibitor niraparib with dostarlimab that did allow T1Cs just over a centimeter in that study, and hopefully for TNBC we will see that data reported soon as well.
I mean, the NeoSTOP, NeoPact both did. There's other individual IITs that we all allow T1Cs, because we kind of treat them similarly to our 2.3 centimeter tumors. But the big randomized studies that define our, treatment algorithms just...
And labels.
Yes. Yeah. So the patient does receive neoadjuvant chemotherapy, has a lumpectomy, has a 7 millimeter residual grade 3 cancer, 3 negative sentinel lymph nodes, with treatment effect in one of them. And Julia and I had the conversation about treatment effect just this last week. So, the questions here are, what adjuvant therapy will you recommend? There's unfortunately not a PCR. The patient didn't get immunotherapy up front. Would you try to use it based on ABRAVE data, where there seemed to be much numerical benefit, a little bit, at least in patients who receive preoperative therapy, or just stick with CAPE or do something else?
I already said in my talk, I am not attempting to give adjuvant immunotherapy. I think the data is unfortunately not very robust, and I think you'd have probably a very difficult time getting insurance authorization for it. And I also think that there's probably a lot to just the concept that the optimal anti-tumor immune response is likely generated with an intact tumor. So the opportunity to benefit substantially from immunotherapy comes from likely the administration of it in the neoadjuvant setting. So I would not give adjuvant immunotherapy to this patient. If they're germline BRCA wild type, I would give adjuvant capecitabine. If they had a germline BRCA mutation, I would give them adjuvant olaparib.
Agree.
Yeah, same. I believe in that biologic hypothesis, and I think we can't really justify the risk of the immunotherapy.
So Julie, what about radiation?
So,
One lymph node with the treatment effect, it
Oh,
was
God.
clinically and radiographically negative.
So I have to be really honest. I feel like I'm pretty experienced as a breast cancer radiation oncologist, and I don't know why I would let treatment effect in the lymph nodes change my mind about a node-negative case. I would not give this patient regional nodal radiation. Again, I want to really, she is a BRCA-negative patient, and I just want to emphasize that breast conservation is very, very safe in triple-negative patients, despite how the trends in treatment in this country. And so if she had had an intact breast, I'd treat her breast similar to what I described. I would give whole breast irradiation. In my hands, in someone this age, it would still be 15 treatments where I'm going to dose escalate if I can find the cavity. To the high-risk region in the breast. If she had a mastectomy, she would be, in my opinion, she's done with her local regional therapy. I appreciate that there's concern about treatment effect, but I and others have gone, and there's a lot of talk about it, and we hear a lot of people say how it influences their thinking, but in terms of adding radiation therapy on, I would love, if I might be wrong, please let me know, but I can find no data supporting that we need to give radiation when we see treatment effect. And this is particularly important following B51-1304 trial, where we show even if we can prove you have a positive node before neoadjuvant therapy and after adjuvant therapy, it's negative with or without treatment effect. The radiation to the nodes adds very little post-mastectomy or with the breast afterwards, and in fact, not at all. Hazard ratio of about 1 without radiation. So it's just, it's good news for patients. This patient does not need regional nodal. Hopefully she had a lumpectomy.
Yes, she had lumpectomy, yes. In these cases, almost everybody has a lumpectomy. So it's a little bit different than what happens in clinic, but so a 52-year-old with HER2 positive, ERPR negative, de novo metastatic breast cancer presented with liver and bone disease, receives first-line THP with near complete response in liver lesions and maintenance HP for 18 months. Followed by disease progression, a switch to TDXD, PR in liver, which was, maintained for 12 months, now has brain lesions. She's asymptomatic from these brain lesions that are 6, 7, and 9 millimeters. The systemic disease is well controlled on TDXD. How would you balance, treating both the brain and the systemic disease? You treat the brain and continue TDXD. You don't treat the brain and just follow because the patient's on TDXD, which does penetrate the brain. Switch the treatment to a different combination that gets to the brain, but still monitor the brain, or treat the brain and switch the treatment. So many options, but these are really the options that are there.
Yeah, I think we are often trying to weigh how to treat the CNS versus how we're treating the systemic disease when they're out of sync. And in this case, I would use SRS to the brain lesions. I think treating them early to prevent symptomatic disease later is important, and to control the volume and prevent leptomeningeal spread is important, but I probably wouldn't change the systemic therapy. And let's follow this patient after SBRT and see, and if they progress at that point, either consider more SBRT if it's a very small progression, or then moving on to the HER2 climb regimen. That's just my approach, but
Yeah, I fully agree. I think the key here, or the two key things, one is that the extracranial disease is well controlled with TDXD, and then the second, that the CNS lesions are asymptomatic. And so I think I agree. I would favor an SRS approach for the CNS lesions, continue to monitor. I think the patient is at risk of potentially having disease progression, within a short time frame, but monitoring closely, and then when there is a change in extracranial or even intracranial disease, then at that time potentially, considering a switch to the HER2 climb regimen.
And I'll just add, I think, I'm not sure that this patient had we don't know what the status was of their brain before this brain MRI.
Yes.
So it's also possible that the TDXD was actually working, right? Because we don't know what the baseline was. And I actually think that brings up just a really super practical point of how should we do CNS imaging in our patients who don't have neurological symptoms that have HER2 positive metastatic breast cancer. It's interesting. It's actually not incorporated into the NCCN guidelines that we have to necessarily image the brain. I will tell you I do, largely just because I think now that we have so many systemic therapies that get good CNS penetration, I think that this factors into our decision making about what to do. But this is an interesting example of, just sort of, they got the brain MRI, but we don't sort of know where things started. It's entirely possible for this patient that TDXD has already shrunk these brain metastases, which is why I love the option of SRS and then monitor and continue the TDXD.
Let me just add that I think Energy Oncology tried to run a trial where we did screening in HER2 positive breast cancer for brain with MRIs, and unfortunately could not get it through because of the cost of the MRIs. And some institutions saying I always do it, and some institutions saying I never do it, and most people saying I try to do it. But I would totally agree. I think this is a population of patients. Doing the first SRS is great, but I think this is there's ongoing studies that I would really encourage us all to really pay attention to, because I think we have to be careful that we don't keep on SRSing people who might be maintained on a drug, particularly if they have systemic disease at the same time, and it'll be great to get that answered.
Okay, this is a 61-year-old with ER positive grade 2 IDC, PT2N1, receives adjuvant chemotherapy, endocrine therapy. A year after finishing endocrine therapy, has metastatic disease to lung and bones. Lung biopsy shows the disease to still be ER positive, HER2 1+, receives the first-line AI abemaciclib and good disease control for 12 months, then has progression in the lungs. Tissue and ctDNA genomic testing is negative for targetable mutations. Receives fulvestrant everolimus for second-line endocrine therapy, stable disease for 6 months, now more progressive disease. Again, the repeat ctDNA testing is negative. She's asymptomatic from this progressive disease. How would you approach this individual? You try to come back in with another CDK at this point, move to chemo, which I put TDXD along with chemo, but, we understand it's a little bit more than just chemo, yeah.
This is a great question. I think we're increasingly seeing these kinds of, this scenario and having a discussion with the patient about the data, right? So here we have a patient who's received 2 lines of endocrine therapy, appears to be asymptomatic from metastatic disease, relatively limited burden of tumor. And so I think here the discussion is, in a patient with HER2 low metastatic breast cancer, is discussion of the DB06 data, right? So do we consider an option like TDXD or a standard chemotherapy like capecitabine? And I have to say, while we await the overall survival data from DB06, there is a 5-month improvement in median PFS favoring TDXD versus standard chemotherapy. I think it is very important to consider the toxicity profile and differences. Capecitabine is overall, a well-tolerated oral agent. The scheduling is convenient, does not require IV infusions, is not associated with alopecia. Not to mention, of course, that with TDXD, we do need to monitor very closely for ILD, pneumonitis, and I do CT of the chest every 6 weeks while on TDXD. So I think there certainly are differences in terms of the toxicity profile. So I review the data with patients, and I would be comfortable offering capecitabine to this patient given the limited burden of disease. That said, I think it does raise, if we do see an overall survival benefit from DB06, if there is a demonstrated benefit to positioning the ADC first, then I think that changes the discussion. Now, whether or not we will see an OS benefit in some of these trials that are looking at ADCs in the earlier setting, I think that is a big question, right? That remains unanswered because there will be many patients who receive ADCs in the control arm subsequently, and how that might impact how we interpret the OS data, I think is going to be very challenging.
And ideally, if there should have been 100% crossover, because that's what we want to see.
Exactly. Which brings me to my next point, which is I think it's very important that we design studies that are looking at optimal sequence that explore crossover options. I think we clearly need to answer this question about what is the preferred initial ADC or chemotherapy. Does it matter which sequence you give those agents? And clearly a better need to develop biomarkers to select our initial approach for therapy.
Anybody would consider coming back with endocrine therapy in some way, shape, or form?
Yeah, I've done it. I mean, I will say capecitabine would be my preference here, and I'm not sure if the overall survival data will change what I do, because I do think there's a lot of value to delaying the time to IV therapy and more toxic therapy as long as possible. I am a little concerned because there was only a 6-month period of control here. On the other hand, I have seen activity with switching CDK4/6 inhibitors later on. There is some data to suggest that it may be good to give an intervening therapy and then go back to the CDK4/6 inhibitor because of switching that can happen between cyclin D and cyclin E, that is. But, so I've done it and I've seen really great responses. And I think here's where the art comes in. There isn't going to be one right sequence for every patient, in my opinion. And it's really about trying to preserve that quality of life, trying to keep this patient not coming into the office as much as possible, and keeping those side effects under control.
I'll second what Dr. DeMichele says. I'm also not sure that even if the DESTINY-Breast06 data demonstrates an overall survival benefit, that's going to change my practice. And I say that because if in the control arm, only a small percentage of patients received subsequent TDXD, that really actually doesn't answer my question, right? Because if I give TDXD in the first line setting, versus in the second line setting, and if the overall survival were equivalent, like we have talked about, delaying the toxicity of the IV therapy is a very important quality of life consideration for our patients. So I think it'll be interesting to see how that pans out, but I'm not sure that will actually would change our practice.
Yeah. Move on to our next case, 58-year-old with metastatic ER positive and HER2 positive breast cancer with liver and lung mets, diagnosed 3 years after completing adjuvant TDM1. While on adjuvant AI, liver biopsy shows the cancer to be ER positive, HER2 positive, receives the standard THP, 6 cycles with partial response and maintenance HP for 6 months, now with disease progression. Without disease progression. So it's like, now we have the patina data. What do you do with this individual? Don't change anything because things are okay. Add AI and Palbo to HP. Add fulvestrant and Palbo to HP because she had metastatic disease while on AI. Hang tight and add more drugs if there's progression. And I can tell you, we may be doing a lot of endocrine therapy for the maintenance in ER and HER2 positive disease, but the real world data would suggest that many patients don't receive endocrine therapy with part of their maintenance. So this is not that uncommon of a scenario.
That's really terrible.
Based on patina, would you add Palbo?
Well, here's the thing. I mean, I think the data that we have, and again, this hasn't been published yet, so you should know the DSMB met to do the interim analysis on a Thursday, and we presented the data at San Antonio the following Thursday.
That's tough.
So there's still a lot of data cleaning going on and queries. So let's publish the data and see it all. But I think, and this patient has been on HP for 6 months doing well. I do believe that an ER-positive patient should be on endocrine therapy if they are, on the maintenance phase. Would I add Palbo? Probably not yet, but that is something to consider in the future. And again, to really delay. And this is pretty easy treatment to take, but it is expensive. There are side effects. So if the patient's doing well on HP and endocrine therapy, we may be able to do without it, not add it later.
I completely agree, and I think just to underscore the point you made about the biomarkers being so critically important, I just saw on Thursday this week in my clinic, a very similar situation of a patient of mine that's been on maintenance HP and an aromatase inhibitor for 7 years. And just got another set of scans and continues to have stable disease. And that would be a patient that, if I had given a CDK4/6 inhibitor to, 7 years later, that's a lot of added toxicity, a lot of added, cost. And so the biomarkers here, I think, are just gonna be so critically important because it's very clear, probably some people will benefit from that approach, but understanding who they are is critically important because there are some people that have really excellent long-term outcomes without it.
So next, the question that we are starting to deal with quite a bit in clinic, somebody who's been on TDXD has a great response, but about a year into it, that's when patients start really complaining. There's impact on quality of life, and yes, the disease is well controlled, but can I be on something a little bit more tolerable for maintenance? Like, you go to HP plus endocrine therapy, or just take a break and do nothing for a period of time. It's something I struggle with a lot in clinic.
And I think this is the next question as we await the data from DB09, right? So if DB09 does meet its primary endpoint and TDXD becomes the preferred first-line option, the question is, can you do similar to what we do now with an induction phase with THP, stop the TDXD and then switch to a more tolerable, maintenance regimen, and now you can even give HP subcutaneous. And so here for this patient who, based on side effect profile and quality of life, is looking to switch, I would consider switching to HP in this instant. I'm eagerly awaiting the DB09 data, but that question will not be addressed with the study. And I would add on an endocrine backbone as a do-win maintenance strategy for HR positive, HER2 positive breast cancer. I think the question about the CDK4/6 inhibitor after first line TDXD, that's another big question that remains unanswered, but here I would probably favor an HP plus endocrine.
And one wonders, if DB06 is positive, we started doing that first line for all patients, the dual positive patients, are we really because we won't be giving endocrine therapy with TDXD, right? So maybe we're negatively impacting their long-term outcomes in some way. We won't get to that 7 years on maintenance. And
I think this is going to be a huge problem because we're not going to know who should start with the TDXD and who's okay not to, and that's where the biomarkers are so key. I think there are a couple of tools that can be very helpful here. A PET CT, for example. I mean, we have patients who get a complete metabolic response, and in those patients, I mean, I feel quite comfortable thinking about switching therapy and knowing that if I get a surveillance PET and their SUVs are coming up, then maybe I need to switch back. And then maybe there's some role for ctDNA in this kind of situation, right? And so I think we're going to have to start thinking about those kinds of tools to help us modulate the different therapies when we have so many choices that have very different toxicity.
Are you using, though, FES PET, or are you using straight PET in a patient like this?
Well, we're using straight PET in a patient like this because of the HER2 positivity, but it's remarkable how quickly with TDXD you can see a complete metabolic shutdown.
Yes.
we have a lot of trouble getting repeated PETs. Sometimes you can, but then there's patients you can't, and then you've had 2 PETs, and now you have to get a CT, and you're comparing apples to oranges. So I've just switched to just doing CTs because then I'm neither here nor there.
I agree, and we do have that trouble too, but I like it when I can get it because of that.
I mean,
metabolic
ideally, I'd
piece.
like to get both together, right? So they give, but no insurance would cover that, yes.
You know, I think there's also going to be an issue of how people present. I mean, if you've got impending visceral crisis, that's one thing. Yeah, I might go first-line TDXD once if we see DB09B positive. But if you've just got bone-only disease, soft tissue disease, like I want to take the least aggressive approach that I can take in that situation.
And I think I completely agree with what Dr. DeMichele just said, and a shout out for one of the TBCRC studies that's looking at these exceptional responders after a few years of treatment with HER2-targeted therapy in the first-line setting who have achieved an excellent response, and looking at stopping HER2 blockade after 3 years of maintained response, and utilizing ctDNA to monitor patients over time, because I do think that there clearly, could be a huge role for implementation of non-invasive biomarkers here to help guide selection and duration of therapy.
One of the MRD tests kind of use that to make this.
Because I think, you're going to see ctDNA in most of these patients because they have metastatic disease at the time they present. And so it's the dynamics that will be so important. If you see disappearance of the signal in the blood because they've had such an exceptional response, and you can follow that, that's going to be very helpful. And maybe even, initially we're going to have to do it with scans, but over time we may get to the point where we don't even need to keep doing so many scans and we can just use the blood.
I think we're running out of time. I had another case, but we'll just skip that. But thank you for a great discussion and all your wisdom and sharing your experience. So